Good afternoon. Thank you for joining us today. I'm going to just take a couple of seconds and let people load into the Zoom room because we know with a webinar, it takes a little bit of time. We are grateful to have you with us on this rainy afternoon. Good weather is coming though. So good afternoon. I'm Michelle Wagner with NAMI New Hampshire, and I work on the First Episode Psychosis Early Serious Mental Illness Initiative. Thank you for joining us for today's webinar titled Navigating Tardive Dyskinesia, Empowering You and Your Loved Ones Through Knowledge. This presentation is being recorded and you'll be able to find it on NAMI New Hampshire's YouTube channel. In the next couple of days, you'll receive a follow-up email with links to both an evaluation and the recording. This is Zoom webinar. That means your camera and microphone are off. We cannot see you. The question and answer feature is working, so please enter any comments or questions there. We'll be sending you things through the chat, but you're not able to post in the chat. And now I'm going to introduce our presenter. Joining us today is Dr. Mohammed El-Sayed. He is a clinical assistant professor of psychiatry at the Geisel School of Medicine at Dartmouth and a psychiatrist at New Hampshire Hospital. So Dr. El-Sayed, thank you for being with us today. This is a very important subject, and I'm going to turn it over to you so you can help our audience learn more about tardive dyskinesia. And if you will, can you share with us why you got into this field to start us off?
Absolutely. First, well, thank you for inviting me to this lecture. As you said, it's a very important topic. So when I was in medical school, I didn't really think much of being in mental health. My whole passion was to be a neurologist. And then one day, when I was talking to my wife, she received a phone call from one of her friends who was also a medical student at the time. Apparently, he has been struggling with depression, and for a very long time, none of his family member knew about it. And he's been using alcohol to help him with his depressive symptoms. And he did mention his thoughts about ending his life. So she and I discussed it thoroughly after this happened, and we thought, well, as well, we're just graduating medical school. We thought, well, we think it's best for you to go to the hospital. And he threatened then that if he ever goes to the hospital, if he was forced to go to the hospital, he would end his life. When we reached out to his family, they did take him to the hospital. And unfortunately, the doctor who was on call on that day didn't think much of what the patient, with what he was saying, what our friend was saying. And he ended up ending his life on the same night. And that was like a life-changing event for me. So, and for my wife too. And this is when I thought, well, there's a lot that we can help with in mental health. And there's a lot of need for mental health help at the moment.
Thank you for sharing that. That's a powerful why as to your reason for being in this field. So with that, we're going to turn it over to you to bring your slides up and go through our tardive dyskinesia presentation.
Sounds good. Okay, so can everybody see this? Can you see my slides now? Excellent. Okay.
Yes.
All right. So hello everyone. My name is Mohammed El-Sayed, and today I'm going to talk about tardive dyskinesia. And the main goal of this session is to help everyone understand what it is, why it happens, and what options do we have when someone is struggling through the tardive dyskinesia. I do not have any financial disclosures, and the main objectives, like I said, is to explain the symptoms and the presentations of tardive dyskinesia, to understand the burden of tardive dyskinesia on people living with this experience and the caregivers as well, and then review the available treatment options. So just starting with the term tardive dyskinesia itself. So tardive means late, and the reason we call it tardive is because it usually happens late in treatment. So if somebody starts a medication today, I would not expect them to have tardive dyskinesia in a day or two. The minimum is usually a month, but it usually happens after 6 months of consistent treatment with the medication. And dyskinesia is just an awkward word to describe that abnormal movements. It has different types. It's not just one type. And the types themselves are not very important. What's important is that it's an abnormal movement that happens when someone starts on a medication. So to get to the definition, it means that this is a medication-induced problem characterized by abnormal movements, like I said, of different types. You don't have to worry about the names of them. And this usually persists for at least 1 month after stopping the causative drug. So the main thing here is that no tardive dyskinesia happens because of a medication. So it's not because of genetics. It's not just that someone just woke up and had this abnormal movement. If that happens, so there are some abnormal movements that can happen, but we don't call them tardive dyskinesia. The term tardive dyskinesia means that this happens because of a medication. And before we discuss why it happens, let's just take a look on how it looks like. And then we could understand probably why it is burdensome on some subjects. Symptoms usually happen in different muscles at the same time, but it's most commonly happens in the mouth. All the videos I'm going to share here are videos that you can find online, either on UpToDate website. I have the links. I have the reference here if you want to look it up yourself. And all the subjects have agreed to be recorded for the specific reason. So this is when it happens in the mouth. As you can see, it's involuntary, so the subject do not have control over them. And it's usually very persistent when it happens. So that's the most common form of tardive dyskinesia that we see in clinical practice. Looking at other types, so it can also happen in hands. And as I said, it's involuntary, so subject might or might not be aware that these are happening. And then to show you how burdensome it can be, this is one of the most extreme presentations of tardive dyskinesia.
That one's hard to watch, Dr. El Sayed.
Very hard to watch, yes. So it can, like I said, it can range from mild symptoms that the subject might not be aware of to a very difficult presentation where the person cannot even sit still or walk in the street. Now, as I said, tardive dyskinesia is a medication induced. It's a medication side effect. So all these subjects have been on a medication and at least for 6 months to develop this side effect. So the next question is, what medications can cause this? The most common, and this is why we discuss this in mental health, is antipsychotics medication. There's two classes of antipsychotics. The ones that came out very early in the 50s, 60s, and 70s, and the ones that came late, maybe early 90s. As you can see here, well, I tried to make the size match which one can cause it. So as you can see here, the first generation antipsychotics is the one that can cause this the most. So each year, 5 to 6 people in every 100 and 10 to 25 older adults in every 100 taking these medications can get tardive dyskinesia. Compare this to second generation antipsychotics, where each year, 4 people in 100 and 5 to 7 older adults in every 100. And just so you know, and this is something that we discuss with our patients, if you want to prevent this, so even though the second generation antipsychotics are not marked to cause tardive dyskinesia, they still can do it. The thing is, this usually happens with the pills and not with the longer acting injectables, the one that patients can take once a month or once every 3 months, or even some medication that can be taken only twice a year or once every 6 months. So when the client is taking the long-acting injectable, the risk of tardive dyskinesia is much less than taking a pill every day. Now, this is the most common. This is what we all know about, that antipsychotics can cause tardive dyskinesia, but there are other medications that can cause this as well, like medications for vomiting. If someone has been struggling with nausea and vomiting and have been taking metoclopramide for more than 6 months, they can easily develop tardive dyskinesia. Same thing with other medication that can be used for vomiting. And there are other medications that can cause tardive dyskinesia symptoms, but it's not tardive dyskinesia. So the symptoms are very similar, but these ones are are less persistent, easily treatable. If you stop the medication, they will not show up. Medications, antidepressants like amoxapine, or even SSRIs or SNRIs, Quingentin, and antihistamines. So this is when we talk about who is susceptible. So the susceptible persons are the ones who are taking these medications, but which population from the people taking these medications are most susceptible, or who is at the highest risk of having tardive dyskinesia? It usually happens in older population. If someone is more than 55 years old and they just started on first generation antipsychotic medications, they can develop tardive dyskinesia more than someone who's in his 20s, his or her 20s. Also, exposure to high doses of the medication. So if someone is exposed to high dose of first generation antipsychotics, 1 in 2 individuals can get tardive dyskinesia. So well, just to give an example, if someone is taking a medication called haloperidol and they're taking the highest dose, like 30 milligrams, the chances are 50% of getting tardive dyskinesia if they stay in the same medication for more than 10 years.
And
Women-
haloperidol is Haldol, correct?
That's right. Yeah. Women are more susceptible than men. And if the subject is carrying the diagnosis of schizophrenia, intellectual disability, mood disorder, just having a substance use disorder, dementia, or diabetes. For some of these diagnoses, we know, well, we kind of assume that because when someone has a diagnosis of schizophrenia or intellectual disability, this means that they stay on antipsychotic medications longer in their life, and this might be the reason why tardive dyskinesia can happen. For other diagnoses like dementia or diabetes, we're not really sure why it's more common in them, but this is why when someone comes in, we have to take a full history to understand what side effects, what profile of side effects they could get if they use this antipsychotic. Okay. So you don't need to have a biology background when we talk about why it happens. I'm gonna try to make this as simple as possible. So why does tardive dyskinesia happen, or what do these medications share in common? There is a hormone in our brain called dopamine, and dopamine is a very essential hormone for all of us, because in healthy levels, dopamine can maintain movement and prevents our brain from glitching, prevents us from having shaking when we walk, or falling when we cross the roads. And it also maintains a happy or a good mood. The problem is when dopamine is on an unhealthy or very high levels, this is when it can cause symptoms like hallucinations and delusions. So when someone has high dopamine, we want to reduce this dopamine, and this is what antipsychotics medication does. So antipsychotic medication reduces dopamine in the brain, and this is how they work. This is how they treat the symptoms of hallucinations and delusions. But the main issue is, so this is the good part, that's the good part about antipsychotic medications. The main issue is, none of our medications are selective. They don't just pick the hallucinations and delusions and leave the others. And this is why people can get the movement side effects. Are there other movement side effects beyond tardive dyskinesia? Absolutely. And most of them happen early in treatment. And this is why we tend to classify like early symptoms of early movement side effects and late or tardive dyskinesia. And this is the main topic of this conversation about tardive dyskinesia. So now that we understand that, well, our medications can help in symptoms, but they can also cause some other symptoms like movement side effects. the next step is to understand how does this actually impact our client's life. So when we knew from clinical practice that tardive dyskinesia can cause loss of burden on the subjects and their families, but I think the studies that I'm going to talk about does explain why this symptom is burdensome on people. The first thing that we're going to look at is mental health effects. Then we're going to see how this affects social relationships, physical health, and then vocational effects. So this study was published last year. It was an online survey that was sent out to subjects who experienced tardive dyskinesia daily in their life and their caregivers. And it involved many questions, as we're going to see through the session. The first question was, in the past 7 days, how often did you feel, quote unquote, because of your tardive dyskinesia? So the number of people who responded to this was around 269 subjects who experienced tardive dyskinesia and about 170 caregivers. As you can see here, so this is the percentage of subjects answering and the questions, and this is the color is how many of them thought they never had this because of tardive dyskinesia. If you look at sad or unhappy, just in the last 7 days, most of the subjects reported either rarely, sometimes, often, and always. Same thing with irritable. So most of the people had suffered something. Well, the frequency is important, but it doesn't really matter because the number of people who said never is just very small. Tired or low energy, anxious or worried, as you can see here, unable to focus. And well, someone might ask, like, why would it cause inability to focus? Does it affect the brain in any way? Honestly, not. Well, just because, well, unable to focus or unable to remember things is a symptom of depression. So all these questions are targeting depression symptoms and anxiety symptoms. And as you can see here, most of the clients said that they did feel anxious, depressed, unmotivated, even embarrassed or withdrawn because of the tardive dyskinesia. People can feel afraid of being rejected. And as I said, they can sometimes feel unable to remember things. Now, moving from this to how did this actually affect the social life? It's the same question in the past 7 days. How often did your TD, and then questions afterwards. Impact ability to enjoy things you do for fun. Most of the people answered at least rarely, but lots of people said always do. Limit social activities, same thing. Limit social activities because of difficulty speaking. As I said, the mouth muscles are the most ones that gets affected by tardive dyskinesia, and you can understand why this could limit social activities because it's very hard for the person to speak in social events. It can interfere with ability to socialize with friends. It can limit appearing on videos such as Zoom or House Party or FaceTime, interfere with ability to socialize with family. And as you can see here, well, I don't have to go through all this. As you can see here, the never ones are very, very small. So it's like 10%, at least 10 or 15% would say never, but most of the people say, oh yes, this happens to me. The rarely, sometimes, often, or always doesn't matter, but at the end of the day, it does happen to them.
And Mohammed, I'm just thinking about if someone's on Zoom, they actually get to see themselves with that tardive dyskinesia, those movements.
Absolutely. Yeah, that would make it even more embarrassing to them because they see themselves while this is happening. Some people said, well, at the end, it can prevent them from even leaving the house. So going from social relationships to, does it actually affect physical health? I mean, if you could think like, does this movement can affect somebody's physical health? To me, it doesn't. I can't find the relationship, but right here you can actually see it in their answers. It does impact the abilities to fall asleep. It does impact the ability to stay asleep through the night. Abilities to exercise. Like I said, if we saw the most severe one early on, imagine this person trying to walk in the street, or imagine this person trying to exercise. It would be very, very hard for them. Ability to hold things. The fact that they have to eat slowly to avoid choking. We spoke about the speech difficulties, worrying about choking, having trouble eating because of choking, and then having trouble chewing. Speech difficulties made me self-conscious, and as you can see here, and this is what Michelle was alluding to in Zooms, like people can be very self-conscious when they speak or when they see themselves on the camera. Does it cause pain? Apparently, yes, it does. It does cause pain for most of the subjects who answer the questionnaire. Does it affect the ability to eat? It does. They need help with usual activities. They needed help using stairways, and it impacted the ability to bathe or shower. And then going to even daily activities like buttoning your shirt, brushing your teeth, pulling on your trousers, lighting, or opening or closing a zipper. Most of the subjects, I mean, right here, some of these symptoms does not happen to everyone. So maybe like less than, well, about 80% of people said that it happens to them, but there's still 80% is the majority of people who answered the questionnaire. Now, does this actually affect the ability to work? So that was also from the same questionnaire. That it asked them if tardive dyskinesia has affected the ability to apply for a job they wanted or needed. And you can, as you can see here, 40% of people. So let's just keep on the light green, because this talks about everyone. So 40% of people were not able to apply for a job or maintain the role in the society as a functioning human being. Seeking a promotion, about same thing, 37 or 38%. 1/3 of them were not able to get the job that they applied to. And even the ones who got the job, they were not able to arrive at work as scheduled. And then pursuing or continuing education was another struggle. It becomes harder for clients who carry the diagnosis of schizophrenia, because as you can see here, almost 50% of them were not able to get the promotion they asked for. 45% of clients who have schizophrenia were not able to arrive at work as scheduled. So, and this is when it becomes very painful, because many clients who do carry the diagnosis of schizophrenia do not pursue treatment. Imagine someone who is doing everything and they're pursuing treatment, and now the treatment itself is causing the problems in their lives. And then talking about activities of daily living. As I said, with bathing and showering, many people have reported this to be a burden. More than 80% of people reported this to be a burden. Attending appointments, communicating with others because of speech difficulties, massaging body parts that might be cramping or moving, driving a car, dressing, grooming, preparing meals, tying shoelaces, gripping or opening things, managing medications, household chores, making or taking phone calls. So as we can see from all of this, that tardive dyskinesia is not just a movement disorder, it's a movement disorder that does impact the person's life. And now we're moving from this to see how it can also impact the caregivers or the family. So the question that was asked to the caregivers was, in the previous 7 days, because of my family members, or because of my persons, important person's TD, how did I feel? So most of the caregivers reported feeling anxious or worried, sad or unhappy, overwhelmed, overburdened, stressed, irritable, annoyed, resentful, or embarrassed. So in general, so now from all of this, we can tell that, well, tardive dyskinesia is not just a movement disorder that affects the person, it affects the person and people around them as well. And the main treatment, the main way to help tardive dyskinesia is by preventing tardive dyskinesia. Because, well, there are available options of treatment, and we're going to touch base on this later on. But the best way is, well, rather than having to suffer, or rather than having to figure out how to fix it, it's better not to have it in the first place. Preventing tardive dyskinesia is the ideal scenario, and it's a joint work between the prescriber, the subject, and the families. From prescriber points, safe prescribing habits is very, very important. So we don't, well, instead of using higher doses of first generation antipsychotics, we can use the lowest doses and try by time to reduce the dose if the higher dose was not needed. Using newer antipsychotics, as I said, well, no medication comes without side effects. So newer antipsychotics have their own issues with diabetes, with stroke, with whatever. But since this lecture is just about tardive dyskinesia, if someone develops or is starting to develop these symptoms, maybe it's better to switch to another antipsychotic where they can hopefully not have tardive dyskinesia, and there's an easier way to manage the other side effects. And then also the health education part for subjects, for their families. We're going to talk about resources that you can use by yourself or with your family members, so you can read more about tardive dyskinesia in between your visits to your prescriber. So the first door is always your prescriber, your doctor, and your outpatient team. But if you want to read about it yourself, there are other ways to support you. And the main thing is, why do you need to go to the prescriber? Why do you need to discuss with your doctor? Is because we need continuous monitoring. If this happens to you, if you started to develop symptoms of tardive dyskinesia, you need to discuss it early on when it happens. Managing this when it first happens is much, much easier when it's like 10 years down the road. Does this mean that there's no hope for you after 10 years? Absolutely not. It just means that it's easier for you and for your family and for your doctor to work on it early on rather than wait for 10 or 15 years with the side effect. So when is a good time for my doctor to discuss this side effect with me? There's no right or wrong answers to this question. Ideally, well, it's better to have the conversation as soon as you start on the medication or as soon as the client starts on the medication. However, because of the nature of the medications and the nature of the diagnoses that this medication can help with, many clients are not able to have a meaningful conversation with their providers early on. For different reasons. Some of them might think they don't need the medication. Some of them might think, well, my providers are, well, they would have active symptoms that will prevent them from working with the provider. So would it be meaningful to have this conversation about side effects early on? For most people, yes. For clients who have active symptoms or having delusions or hallucinations, it will be very hard to have this conversation early on. So they might need to stay on the medication for a while first, so they would understand the need for the medication, and then their doctor or their prescriber would discuss with them what this medication is for, and most importantly, what side effects they can develop from this specific medication. But this kind of conversation needs to happen during treatment, with the prescriber, with the caseworker, with the social worker, with the team, with the family, because it's very important for the client themselves to understand what they're going through and what they should expect in the future. Moving on from prevention of tardive dyskinesia to treatment of tardive dyskinesia. So as I said, there are treatments options available, and it's not one size fits all. So there's always we always try to make it specific and unique for everyone according to the symptoms and according to what they're going through. One of the variables, so right here, I'm just going to list a few variables of why when we consider treatment for subjects with tardive dyskinesia. So the first question that we ask, like, does this client need long-term antipsychotic medication, or in case of vomiting, metoclopramide treatment? Do everyone having the diagnosis of schizophrenia need to be on long-term treatment? No. Does this mean that the patient or the client can stop the medication by themselves? Also no. There's a new concept coming now into psychiatry called deprescribing, when the provider, the family, and the client work together to stop the medication if the patient does not need the treatment. And they would just monitor and see how the client does without the medication. If the client lives the life okay, they don't need the medication, the life has been okay, then great. Then they don't need that medication. If, on the other hand, the client did develop some symptoms and they needed to be on medication, then this is a kind of discussion that we need to have afterwards. Like, we tried without medication, sounds like you still need the medication. So the next question would be, did the client need long-term treatment with this antipsychotic? Like, well, as I said, there's at least 40 antipsychotics available in the market. Do they still need this one, or can we switch them to another one that does not cause TD? In most of the cases, people tend to stay in the medication just because they haven't tried other medications and this one worked. So why bother switch to something that might or might not work? But in other cases, they don't actually need to be in that specific medication. They don't need to be in haloperidol. If we switch them to another medication like clozapine, they would not get the tardive dyskinesia. I mean, not saying in any way, shape, or form that clozapine is a safer medication, because itself has a lot of side effects, but it doesn't cause tardive dyskinesia, which is the topic of this session. So this is another kind of discussion. Like, if they don't need this antipsychotic medication, then why don't we try to switch them to another class of antipsychotics? And then, well, let's say that they do need the antipsychotic treatment. They do need to stay on this medication. Then the next question is, how severe are the symptoms of tardive dyskinesia? If it's not as disfiguring or as stigmatizing, or it's not affecting their daily activities, maybe they don't need treatment. Maybe because again, when we offer treatment, the treatment comes with side effects. So if they don't need treatment, then let's just keep it like this. And if it ever becomes worse, or if it's ever stigmatizing or disfiguring or affecting the patient's life, then we can discuss, well, now we can add treatment, but well, bear in mind that the medication that we're adding also have side effects. Okay, so now in this slide, I'm going to focus on subjects who do need the same antipsychotic, and they do have severe symptoms of tardive dyskinesia. Are there treatment options? Yes. This is not really the topic of this lecture. But just to give you an overview of available options, those medications, the first three medications are the one that came to the market most recently. The tetrabenazine came out in 2008, and it was already FDA approved by then. The deutetrabenazine and valbenazine, they were both approved by the FDA in 2017, and they do make people better. People do feel better on them. But we don't prescribe them to everyone because they themselves can cause fatigue, they can cause somnolence, so they can themselves affect the patient's quality of life. Other medications that we can use, like benzodiazepines and amantadine, they can all help, but they all have their own side effects. And most recently, neurosurgeries like the deep brain stimulation that apparently, well, it was approved for Parkinson's, so people had the same concept, like, well, if it works for Parkinson, why don't we use it for tardive dyskinesia, which is essentially a long-term side effect that looks like Parkinson. It has limited data on it at the moment, but the data that we have so far from about 11 patients does show that it is helpful. And just bear in mind that these are all if you or one of your family members does have tardive dyskinesia, you can't just rush into taking these medications or just asking these medications. It's better to have a full, thorough conversation with the provider about, like, well, do what I have right now, does it need treatment? And if it does, well, what are my options? Okay. So I was in my psych rotation in med school in 2008. And I just wanted to show you how much of a difference we think of tardive dyskinesia between 2008 and now 2024. So in 2008, when I was in my psych rotation, tardive dyskinesia was thought of as a permanent and persistent condition, and remission would only happen in 5 to 40% in people suffering from it. And now in 2024, what we think of it is tardive dyskinesia is reversible, and remission does occur in 50 to 90% of people. But the key to remission is consistent following up for early detection. Like I said, if you follow up with your prescriber, with your doctor, you would be able to see it. And when they see it, they will be able to stop the offending drug and offer something else that would not cause tardive dyskinesia. So are there available resources for you and your family in case you have symptoms of tardive dyskinesia? Absolutely, there's a lot. the most important is the National Organization for Tardive Dyskinesia. They do have a tracker app available, and the app is available on iOS and Android, so you can get it on any phone. And the app does help you. The app is for you to support you, so you can understand when it happens. You can actually record it. You can text it or email it to your physician, and it can report and it can pick up symptoms like anxiety or depression that happens. And if you ended up starting on a medication, it can track how your TD is doing over time to see for yourself if the medication is helping or not. That's not the only one. The others too, like Talk About TD. NAMI New Hampshire have this annual lecture about tardive dyskinesia awareness. Mental Health America also have their own resources. So if you just put on Google tardive dyskinesia resources, you'll find plenty of them. So this is this is the last part of my lecture. I only have a final thought. So as we here discuss how tardive dyskinesia can affect our population, it's very important to recognize that tardive dyskinesia is part of a broader mental health challenges arising from global conflicts, and what we see in other here in the U.S. and in what people of color are suffering from, and also in Gaza and Ukraine, there's a devastating effect on mental health that can cause intergenerational trauma, and this can cause an irreparable damage. And with this, I will end my lecture. Thank you. And if you have any questions that you cannot ask at the moment, or if we run over time, then you can just email me by scanning this QR code. Thank you.
Thank you so much, Dr. El-Sayed. And are we going to be able to have a PDF of those slides to include with the presentation?
Yes, I can send you a PDF of that.
That would be fabulous for folks. I have multiple questions. Because I have 3 sons, 2 of them take antipsychotic medication. So tardive dyskinesia has been a concern of mine for many, many years now. It's been 14 years since we started this journey with my oldest having a psychotic break. And I feel a push-pull with talking about tardive dyskinesia because I know how important it is to have the information. And on the other hand, seeing the movements, those involuntary movements of people, makes me really frightened. And in looking at the symptoms for caregivers, I was thinking how incredibly sad I would be. I'm very fortunate at this point in time that my sons do not have tardive dyskinesia. But I had seen with my oldest son in particular, who tried a number of antipsychotic medications, a variety of involuntary movements, not tardive dyskinesia, but a tremor to the point where he couldn't sign his name. So I was just thinking when you ran through those slides, how pervasive it is in someone's life affects every aspect of their lives. And so the importance of paying attention to it, as you said, following up with prescribers. And one of the things that jumped out for me was when you were sharing when someone is new to antipsychotic medication and they might be very symptomatic and opposed to medication, the dance that you do with talking about this. I do know that there are folks in our mental health community who are very anti-psychiatry, and that would be hard for them to hear, right? They would feel like, well, that's not okay. You've got to tell people that there are these side effects, regardless of what their mental state is. What would you say to that?
So, well, first, I'm sorry to hear about your son and your children for the having, and I hope in the future we can find other treatments for the movement disorder that we have, that we see in our clients.
Yeah.
Now to answer your question, I fully agree with you. Having an informed decision about medication is warranted, is important in everyone. But when I speak about the dancing and talking about medications, I talk about very specific conditions when clients are resistant to treatment. Obviously, we can't force anybody to take a medication. And most of my, well, all my clients, you receive a handout about what the medication does to them when they first start on medication. The thing is, as well, sometimes the client is not, it's not just about the symptoms, but some clients might be dangerous to self or to the others. And this is when sometimes we need the court to take the decision for the client to start on the medication. And this is so then when we talk about this, the court is we need to describe all the symptoms to the court. So the court understands what happens. The court understands the side effects. But the court cannot communicate this with the client on a long-term basis. They will just understand it because they have to approve the medication at the moment because there is a risk on the client's life or on people around the client. Once this condition is resolved, once there's no danger, this is when it's very important for the physician to start talking to the client about all the side effects that they would expect on the short term and also on the long term, like tardive dyskinesia.
Thank you for that answer. And also too, one of our attendees had said it might help if you stop sharing your screen, which I wasn't aware of because I have two screens up. So I'd forgotten you had your screen up. So that would be great if you stopped sharing. And that was an important answer. I really appreciate that. And medications that don't cause TD, are there antipsychotics that people can take that aren't gonna cause this side effect?
So are there medications that never causes tardive dyskinesia and they are antipsychotics? I I would be very cautious about using the word never. Are there medications that doesn't usually cause tardive dyskinesia? Yes, there's plenty. Most of the second generation antipsychotics like quetiapine, which is famous for the name of Seroquel, olanzapine or Zyprexa, clozapine itself, they all are not known to cause tardive dyskinesia. I'm just making this up. So if 99% of people, they don't cause it. The problem is these medications themselves have lots of other side effects that we need to discuss with the client then. I mean, we're here talking about the tardive dyskinesia awareness, but if we're talking about diabetes awareness or obesity awareness, then this is when we have to bring up those medications because each one of these medications can cause diabetes, can cause stroke, can cause other side effects.
Right. And so my oldest son, who was on a medication that has less of a risk for tardive dyskinesia, now has high cholesterol and high blood sugar and is on medication for that. So at 36 years old, yeah, the risks of these medications.
It's hard.
Yeah. Yeah, it's a juggling act. And I think for many of us, we would like them to not have to take medication. I've worked as a nurse for 20 years, but I'm not a huge fan of people being loaded up on medication. And you made that important point that low and slow and using caution when prescribing. Somebody asked, do medications that help reduce TD symptoms need to be taken long term?
In general, yes. So when someone develops TD, so as I said, this is the last step. This is the last resort. If somebody needs to be an antipsychotic, that specific antipsychotic, and the symptoms are severe enough, then this is when we talk about starting a medication. Do these medications need to be? Do people need to be on these medications? So the 3 medications that were recently approved showed that the symptoms of TD disappear within 6 months of starting treatment, but none of them was long enough to see if they are needed after 2 years. From clinical practice, what we do is we keep the patient on the medication. If the client wants to taper off the medication and try it out without the medication, absolutely, we can try that and see if it stops. If it stops, great. If it comes back, then yes, they would have to stay on the medication for long term.
Okay. And varies person to person, right?
Right.
Such
Absolutely.
variation within
That's a very
med.
specific question. Yes.
Yeah. Okay. Thank you for that. A term that I hadn't heard before, deprescribing. So coming off of medication.
Yes, so deprescribing is a new concept in psychiatry. The concept itself has been around for, I would say, 7 or 8 years. And it states that not everyone needs to be on medications long term. If a client wants to be off medications, this is a very valid discussion. That's a discussion that they can have with their provider. Unfortunately, I know that there's a lot of prescribers who do have this old concept that once on medication, always on medication.
Mm.
But there's a lot of forums from our clients that shows that, well, some of them were able to survive without the medications. There's actually a New Yorker article, an amazing New Yorker article that talks about the concept of deprescribing.
Mm.
So the concept itself came out from Yale, from two of my colleagues, and the New Yorker article talks about how people can live their lives just trying medication after medication, and the answer is for some people is not the medication. The answer is working on your relationships, working on your life, working on getting a job, getting a house. This is what you need. You don't just need a medication.
And that is so important to hear coming from a psychiatrist, right? We're grateful for that opinion and that view. And for my two sons, they feel much better on medication at this point in time. That doesn't mean it is forever, but for now, they both recognize they feel better taking them. So I think it is important to acknowledge for some people, medication is crucial, and for other folks, they don't want to go there. Thank you for giving us that New Yorker article. That's terrific. Oh, I had another question. Wait, we've got something in the, okay. Um, the, um, the fact that it doesn't show up right away, right? So oftentimes the patients that you're seeing in New Hampshire Hospital, those symptoms won't have surfaced in their time with you, correct?
That because these symptoms, as I said, it's tardive, it's late. The earliest it could happen is at least a month from treatment. So for most of the time, we don't see it here in the hospital. That does not mean by any way that these symptoms cannot develop in the future. And this is why continuous monitoring, continuous attending of the appointments is crucial to not just detect it, but also to fix it when it first happens.
And this is where families and caregivers, loved ones can come in, right? Because
Absolutely.
the individual themselves may not recognize what's going on with them, but for family to pay attention.
Yes, and that's and so when we check these symptoms, there's usually a questionnaire that we have. It's called the Ames questionnaire, and
Mhm.
one question is the client or the subject aware of the symptoms? For most of the time, the subject themselves are not aware until somebody tells them, "Oh, what's happening with your hand? What's that on your mouth?" And that's why the family and caregivers are very, very important and play very important and essential role in identifying and hopefully treating tardive dyskinesia.
So AIMS, that scale is the abnormal involuntary movement scale, right?
That's right.
So
Yep.
that's what the medical field uses to
Yes.
assess. Yeah.
Yes.
And how often should that be done, Dr. El Sayed?
Um, it's usually every 3 to 6 months.
Okay.
Or if somebody develops symptoms in between the assessment, then it needs to be done in the next visit.
Yeah. Yeah. And so a call to the prescriber's office to say,
Yes.
hey, you need to see this person. Let's get them in ASAP.
Right.
And I have been that family member that at least twice, maybe three times, I have said, you need to go in and see your doctor because I'm concerned about what's going on. So as a family member and a former nurse, I'm kind of on high alert. So yeah, because this is serious.
And
Yeah.
it's important to detect it early. Don't wait.
Right, right. That is key. One of the things we tell families, and my colleague is on with us, Martha Dory, is a tech support for us. She staffs the information and resource line. And I know that she often tells families, even if your loved one rescinds their release of information with those providers, so now the doctor or the whomever isn't going to talk with you, the clinician, you can still talk with them. So if you have concerns about your loved one, you can still call that office and say, I know you can't give me information. I'm just giving this information to you. So if there is any concern, to make sure you communicate that to someone who can do something about it.
Exactly. Rescinding a release means that we cannot deliver information, but
Mhm.
we can always receive information. We will not respond to it. We will not confirm or deny that we have this client in our caseload, but we can take the information when somebody wants to volunteer with the information.
Yeah, that is really important. And I'm just thinking about last year, we had done a tardive dyskinesia webinar. It was an interview with Todd Donovan, who is the president of our board at NAMI New Hampshire and has tardive dyskinesia, which developed many years ago. So he shared his personal story with us, and I'm just putting the link here for that recording on our NAMI New Hampshire YouTube channel, so folks can access that there. Um,
And I
because,
have okay,
yeah,
sorry.
no, please, you.
Oh, I have to commend Todd on the bravery that he wanted to share his own story with tardive dyskinesia. Like I said, it's for most people it's very stigmatizing. It's people don't feel okay about discussing this, but what Todd is doing as the president of NAMI New Hampshire and also in this specific lecture is amazing. He's trying his best to destigmatize these symptoms by providing an example.
Right. And it's on Todd's face. He blinks and he squints a bit. So it is apparent that he has something that looks like a tic when he's talking. In fact, I didn't even realize that it was tardive dyskinesia until we were going to do this presentation. And I'm like, oh, that's what that is. Okay. So I think that's a good lesson too, in that it can show up in a variety of ways. It isn't just going to be that lip smacking or the tongue thrusting or hand movements, right? It showed up for Todd with that blinking.
Like
Yeah. Yep. Um, and you did talk about, because I know at least one person on this call has a loved one who's had tardive dyskinesia for years and it hasn't been addressed. So you had said folks, even if they've had it for a number of years, can still get treatment for it.
absolutely. As I said, there's always hope. Uh, when I say that do not wait is because we don't want this to affect the person's life or the loved ones as well.
Mm.
But the medications that are available in the market are helpful. They can provide assistance to the symptom of tardive dyskinesia. Would it take some time for the subject to get better on the medication? Yes, it might. But at the end, the medications themselves still can help.
Yeah, that's really good to know. As long as the side effect of the new medication doesn't make it
Right,
worse. That's key.
right,
That is key. And as we know, everyone's different.
absolutely.
And I think I'm just checking, no more questions in the Q&A. So, what are your takeaways for folks, Dr. El Sayed, from today's conversation?
I guess so I have two thoughts. The first one is the tardive dyskinesia itself is an example of how there is always hope. When I was in middle school in 2008, back then we thought of it as irreversible. There's no cure. When it happens, that's it. And now after 15 or 16 years, there is three available treatment options that are approved and that shows that it can help people. So the first thought is, well, there's always hope. So if one medication does not work for you, and you feel that, oh, this is it. No, this is not it. There's always hope. You can still try and work with your doctor and your outpatient team to find the medication that's suitable for you. The second thought is what's more important than the medication is having consistent follow-up with your provider. Once you follow up with your doctor, I mean, we're all human beings, and you should be treated as a human being. When you meet with your provider, it's not about prescribing you a pill or giving you an injection. It's more about understanding how this whole thing affecting you and yours lives. Um, feel free to, usually most of providers try to make the office as a safe zone where you can talk about any concerns. And if you're feeling that this side effect is a burden on you, a burden on your family, feel free to discuss it with your doctor. Don't shy away from bringing this up in conversation, because once you bring it up, we can discuss the solutions. When you don't bring it up, I mean, yes, there's ways that we can assess for tardive dyskinesia and other symptoms, but most of the time we're not here with you. You see the doctor once a week or once every couple of weeks. We're not here with you to understand how this is affecting your life. Don't shy away from bringing up these concerns to your doctor, because at the end you're a human being and you need to be treated as one.
That's a beautiful message. And if that doctor isn't listening, find a new doctor.
That's right. Yes.
Oh, thank you so much for being with us today. It was a fabulous presentation, and I put some links and sites in the chat, so take a look at those. And just a reminder, a recording of today's discussion will be posted on NAMI New Hampshire's YouTube channel. It's going to take us a couple of days to get that up, but we will get it there. And you are going to receive an email in the next couple of days, which will include links for the website along with the evaluation. So once you've completed the survey, you're going to automatically receive a certificate of attendance for folks who need that. For any questions or comments, please reach out to me at mwagner@naminh.org. That is in the chat, and we look forward to having you join us for our next webinar. Until then, take good care. Thank you all.